I'm now going to move on to connective tissue disorders that have to do with joints. And the first disorder I want to talk about is Ehlers Danlos syndrome. Ehlers Danlos is a family of disorders related to abnormalities in joint hypermobility, easy bruising, and kind of hyperelastic skin or stretchy skin. The syndromes derive their name from two physicians, Edward Ehlers, a Danish dermatologist in 1901, and Henrik Alexander Danlos, a French physician with expertise in chemistry and skin disorders in 1908. There are actually a number of different disorders called Ehlers-Danlos syndrome, but they actually have very little to do with each other, except for they were described and characterized by these two men, Dr. Ehlers and Dr. Danlos. So the various forms of Ehlers-Danlos are caused by a variety of abnormalities in the synthesis and metabolism of collagen. And again, as I stated in the last module, there are 25 different genes that code for different types of collagen. And in the case, if we remember, in osteogenesis imperfecta, even different changes within the same collagen result in different phenotypes. So there are 15 of the 24 genes carry 19 different forms of collagen molecules. There are other components to connective tissue, such as elastin and other proteins, that are often also woven into this microfibrillar array to help with tensile strength. So classic Ehlers-Danlos or Ehlers-Danlos type 1 is inherited in autosomal dominant fashion. It occurs in about 1 in 10,000 individuals, and they have changes or mutations in the collagen 5A1 and collagen 5A2 gene. Collagen 5A1 is located on chromosome 9, and collagen 5A2 is on 2. Mutations of one of these two genes is identified in about 50 to 90% of patients who fulfill the clinical diagnosis for Ehlers-Danlos or EDS type 1. Originally, it's only been in the last maybe 20 years that we've had all these genes. I always like to say, all the tools in my toolbox. I used to have to make all these on a clinical basis. So, clinical characteristics. Skin is fragile, velvety, and smooth. It's very stretchy. It's almost like kneading dough, and it's very you can pull it out, as is being described in this photograph here. Super flexible, easy bruising. The reason that there's easy bruising is because bruising is caused by bleeding in between connective tissue. So as it's like moved, there's a little bit of bleeding underneath. And very poor wound healing. These kids, they can fall. Often they have to wear chin cups and things over their head because they fall and they hit their head and it breaks open, especially under their chin. This particular little boy that actually has OI type 1, mom used to carry around suture wherever she was, special suture from a plastic surgeon. You need to, repair any cuts in the skin in a two-step fashion, so you can't just pop a few sutures in there. One of the determinations on joint mobility is something called a Beighton score, and there's actually points. So you get a point if you have, for each arm, hyperextensibility. Can you put your thumb down? Either can you put your hands down like this or the extension of the feet. So 1, 2, 3, 4, 5, 6, and then 7, 8, and then 9 is can you bend over and touch your palms to the ground. A lot of people can touch their fingers, but it's actually their palms. Clinical characteristics. The skin has this almost like, again, this velvety and soft, but when I look at the knees, I always like to look at knees of patients that I think have Ehlers-Danlos because they have this hyperpigmented, it almost looks like cigarette paper or papyrus scar. And this is called the Gorlin sign. Not that anyone would actually want to do this, but they can take their tongue and touch their nose with it. Sounds disgusting. Type 4 Ehlers-Danlos is caused by a different type of collagen. Neonates can present with congenital hip dislocations, club feet during childhood,
They're at risk of inguinal hernias, recurrent joint subluxations, dislocation, and patients with type 1 actually have dislocations, so the joint comes totally out. Subluxations, it pops in and out. There's also a risk of pneumothorax and tendon and muscle rupture. Type 4 is actually a very severe disease. Facial features include a thin nose, small ears, easy bruising, mild joint hypermobility. So actually the joint hypermobility is not as severe as in the type 1. But the connective tissue in the aorta can result in either dilatation or ripping. The aorta is, whenever the heart beats, all the blood goes into the aorta. And this needs to have normal strength to stretch, to go back and forth. And in the case of vascular type EDS, it can actually rupture under all that pressure. There's also risk of rupture of hollow organs, including the bowel and the uterus. And in fact, there's a risk of pregnancy rupture of 5.2%, which is a pretty large number. This is the most severe form of Ehlers Danlos, and again, complications include arterial ruptures, commonly involving iliac, splenic, and renal arteries, as well as the aorta, which can result in massive hematoma and death, ruptures of intestinal viscera, thin, soft, transparent skin, but not necessarily hyperelastic as is seen as type 1. And again, we talked about complications of pregnancy, including vascular rupture, uterine rupture, and even if that doesn't happen, tearing of the perineal tissue. The next connective tissue that I would like to discuss is Marfan syndrome. They actually believe Abraham Lincoln had Marfan syndrome, and it's caused by a different component. This is one that's not collagen. It's caused by an abnormality known as fibrillin. And Marfan syndrome is inherited in autosomal dominant fashion. Clinical characteristics include tall stature, and it's tall for genetic height. So it's not necessarily if somebody's 6'7". If your dad is 6'5" and your mom is 6'2", 6'7" might actually be within the expected range. But if you were 6'7" and your dad was 6 feet and your mom was 5'7", then that's tall stature for your expected height. Other characteristics include long spindly fingers, and we know that is arachnodactyly. Arachno stands for spider. Fibrillin, or FBN1, is important in the elasticity of fibers. So it's not enough for it to be stretched, it needs to come back. The microfibrils are necessary for deposition of elastic deposition, and abnormal fibrillin disrupts the microfibrillar formation and leads to abnormal elastic fibers. There's actually 4 components, and now maybe even 5, to the diagnosis of Marfan syndrome. So we're going to talk about the Ghent Criteria, and this is the clinical diagnosis of this disorder. There are 7 systemic features, and that means clinical on exam features, ophthalmologic features, cardiovascular, family history. Approximately 40% of patients with Marfan's have a family history, and then molecular testing, which is relatively new. So systemic features include, there's actually a point system. A pectus excavatum, you get 1 point. If you have a pectus carinatum, when it comes out like this, you actually get 2 points. And again, you need 7 to have enough points. Scoliosis, which is a curvature of the spine. If it's greater than 20 degrees, you get 2 points. Other features include a flat feet, or pes planus. Steinberg thumb sign and wrist. If you can do both of these maneuvers, so when you put your thumb out and your thumb down and it hangs out, you get 3 points. If you can do one or the other, you get a point. And then wings, the lower body greater than the upper, or the wingspan greater than the height. This is actually much easier to measure than determining upper body. Other features include stretch marks or striae, myopia, needing glasses, mitral valve prolapse, which is a weak valve in the heart. These used to be considered ophthalmologic and cardiovascular, but we've actually moved them into systemic features just because they're so incredibly common. Major criteria in eye is ectopia lentis, and this is the upgoing dislocation of the lens. We talked about homocystinuria that has a downward dislocation of the lens. This is upward. Myopia, and again, flat cornea and elongated globe. These are other signs that the ophthalmologist may see in a patient with Marfan syndrome. Cardiovascular features, dilatation of the ascending aorta, aortic dissection, and then mitral valve prolapse, as I said, as a floppy valve, which is a common finding. Marfan syndrome, the gene that causes Marfan syndrome is called fibrillin and is located on chromosome 15. And again, it codes for a protein important in the elasticity of tissue. Patients who fulfill Ghent criteria, 97% have a mutation of the fibrillin gene. So, new Ghent criteria. If there's no family history of Marfan syndrome, you need to have an enlarged aorta and a dislocation of the lens, or an enlarged aorta and a fibrillin mutation, enlarged aorta or the 7 points of the systemic, or ectopia lentis and a fibrillin mutation. So basically you need two things. And one of the things we always need is to know what the aortic root is. When patients come to see me, it's not a big deal to be tall and flexible. It actually makes you a good athlete. It is a big deal to have an aortic root dilatation. So whenever I'm considering the diagnosis of Marfan syndrome, I also always need to look at what the aortic root is. And the best way to do that is through, well, the most non-invasive is through an echocardiogram. And sometimes people do cardiac MRI, but let's just say echocardiogram. In the presence of family history, though, you only need one of these: ectopia lentis, 7-point systemic features, an enlarged aortic root, or the familial fibrillin gene mutation. So this is important if I saw a newborn whose one of the parents had Marfan syndrome. If they tested positive, I would know that they had Marfan's, and then I would want to monitor them very closely with echocardiogram. And in fact, if they were negative, then I wouldn't need to. We've talked about Ehlers Danlos type 4, which is a really scary form of Ehlers Danlos, and Marfan syndrome. Loeys Dietzs is actually worse than either of them, and it wasn't even described till 2005. It's caused by a mutation of one of three genes: TGFBR1, TGFBR2, and SMAD3, and these are all genes involved in the connective tissue matrix. There's actually no difference between the phenotype based on these different genes. They have earlier aortic dissection, on average 26, compared to Marfan syndrome, which is usually in the 40s. Patients have many similar characteristics to Marfan syndrome, including pectus deformity. Aortic root dilatation and dissection can occur very rapidly, however. In the case of Marfan syndrome, it usually gets a little bigger, and then it ruptures. In Loeys Dietzs, it can go from normal to dissection in a couple months. Arteries are usually tortuous throughout the vascular tree, and they also, because of that, the tortuosity, they're at risk of stroke. So clinical characteristics: cerebral, thoracic, abdominal aortic aneurysms and dissections, as well as that arterial tortuosity. They have wide-spaced eyes or hypertelorism, the pectus deformity, scoliosis, joint laxity, arachnodactyly. Again, all of these seen in Marfans. They can have a bifid uvula, so this uvula is in the back of the throat. Velvety translucent skin. Here you can see the patient with a positive Steinberg thumb sign, and this is just trying to show the tortuosity of the vessels. So, a 3-year-old has suffered his third fracture. He tripped over a coffee table. His father had 15 fractures during childhood, but has not had a fracture in 10 years. On exam, he has joint hypermobility, blue sclera. Most likely diagnosis is Marfan syndrome, Ehlers Danlos Classic, osteogenesis imperfecta, Loeys Dietzs, or Ehlers Danlos Vascular. And after these 2 parts of the module, the best answer is OI. So even though there's joint hypermobility,
this is associated with fractures, and OI is the only of the connective tissue that's really associated with increased risk of fractures. And this ends this module.